Thank you, Dr. Roth. Good morning, everyone. Excuse my voice. I'm getting over a little bit of laryngitis, which you'll find is another symptom that can be due to GERD, but in this case, it's not for me. So I'm going to talk about two topics today. The first is, can you have reflux without heartburn? And then the second topic will be, what does it mean if the medications aren't working? So I'll first start by talking about what we call extraesophageal, or outside of the esophagus, types of presentations for reflux. And then what to do, or what it could mean if the medications are not working, if there is a partial or incomplete response to the proton pump inhibitors, if there's no response to the proton pump inhibitors, and potential alternative diagnoses for the symptoms. So, can I have reflux without heartburn? This is an incomplete list of potential extraesophageal presentations of reflux. You have your ear, nose, and throat category, which includes pharyngitis, or basically back of the throat inflammation, ear infection, sinusitis, laryngitis, or inflammation of the voice box, hoarseness of the voice, a globus sensation, which basically means that you feel a lump in the throat even though you haven't had anything to eat or drink, so there's not actually food stuck there. And then vocal cord bumps, which is not something you would see, but something a doctor might see when they look at your vocal cords. In terms of the respiratory category, we have several common conditions, including asthma, chronic cough, pulmonary fibrosis, which is scar tissue that develops in the lungs, bronchitis, and then pneumonia. And then just a miscellaneous category right here, chest pain, sleep apnea, and dental erosions, which are basically wearing away of the enamel on the back of the teeth. I'm going to talk about a few of the more common extraesophageal presentations for a few minutes. So, in general, extraesophageal symptoms can be present more than 50% of the time. There's a couple basic mechanisms that I at least want to explain. The first one is where reflux gets aspirated or moves up through the esophagus and towards the throat, and maybe even back down into the breathing tree. And this is responsible for such symptoms as asthma, the chronic cough, and laryngitis. There can also be an irritation of the nerves that occurs, which can also be seen in asthma and chronic cough, but may also be what's responsible for chest pain that people may feel related to the reflux. So with regard to asthma, up to 80% of patients who have asthma can also have reflux. And in a way, it's a two-way street. It could be that the asthma or the treatment of the asthma is contributing to the reflux. Bronchodilators such as albuterol, which is something that is used as an inhaler on an as-needed basis, what it can do is it can actually lead to weakening of that lower esophageal sphincter, the junction between the stomach and the esophagus, and allow for reflux to occur. But on the flip side, if you have aspiration of the reflux contents, that can lead to spasm or constriction of the bronchial tree, or the breathing tubes that come off of the trachea. Patients who have asthma may want to be considered for reflux if the usual treatment for asthma does not seem to help their symptoms, or in an adult who has just developed asthma symptoms. Asthma tends to be more common, not related to reflux, when it starts out in kids. With regard to chronic cough, reflux is the third most common cause after asthma and postnasal drip. This is usually a non-productive cough, meaning you're not going to be bringing up phlegm with the cough. You should consider this, or your doctor should consider this, if you're a non-smoker and if postnasal drip has been ruled out and you don't respond to inhalers. And a chest x-ray should be done, and if it's normal, then again, consider reflux for people with chronic cough. Now, laryngeal reflux, or as the ear, nose, and throat doctors call it, laryngopharyngeal reflux, basically means that the reflux contents are getting up into the throat and irritating the voice box. This can lead to typical symptoms of hoarseness, frequently needing to clear your throat, a burning sensation in the throat, or even a soreness. And this can also cause that globus sensation that I mentioned earlier. About 10% or more of people who go and visit an ear, nose, and throat specialist will end up being diagnosed with this type of reflux. And a lot of patients won't have the heartburn that Dr. Roth had mentioned, which is the classic symptom of reflux. typically what the ENT doctor will see is they do a laryngoscopy, a little camera that looks at the back of the throat and at the vocal cords, and they'll typically see swelling or redness. And these are very non-specific findings, so the ENT doctor may say that you have reflux, and it may be the case, but there could be other causes for these findings. So this is just something to keep in mind. Chest pain, the last symptom that I'm going to talk about, can be the cause of, reflux can be the cause of chest pain in 50% of people who have been ruled out for a heart-related cause. While it's most usually, or at least half the time, reflux-related, in some cases, patients may actually have a spasm or a squeezing really tight of the esophagus. Patients who undergo an endoscopy to look to see if there's evidence of reflux will have a normal exam most often. And here, pH testing, which involves looking to see does the esophagus get exposed to more acid than is considered normal, may be helpful for making this diagnosis. So the main issue with extraesophageal symptoms is that they can be a little bit more difficult to treat than the classic presentation for reflux. They can still respond to the proton pump inhibitor, but it may require a longer treatment duration before any meaningful impact is seen. And by longer duration, I mean 2 months or maybe even a little bit more. Dr. J. Lee will be talking about surgery later, but some patients may be considered for surgery if they have these extraesophageal symptoms. But we see that the people who have the best outcomes are those who have really given the proton pump inhibitor a long enough try and have actually found a response to the PPI, as opposed to those who don't respond. So now I'll move to the second aspect, what to do or what's going on if the medications aren't working. So first I'll talk about partial responders. These are people who they take the PPIs and they feel better, but there's not complete relief of their symptoms. So in this case, the diagnosis is probably correct. You do have reflux, but maybe there's an error in the treatment. And as Dr. Roth mentioned, there could be an issue with the timing of the proton pump inhibitor dose. It's important to take it 30 minutes before eating a meal to allow for it to get into your system and be working when it's going to be most needed. And if you hear certain themes over and over, it really just highlights the importance of this point that we're making. It could be an inadequate dose. Again, most people will respond to once-a-day proton pump inhibitor therapy, but about 30% of people may require a second dose later in the day or spread out in the day to get better 24-hour control. I will talk about nighttime breakthrough medication or medications that can worsen reflux and lifestyle issues in a moment. And then I'll also talk about potential coexisting disorders that can lead to partial response only. So nighttime breakthrough basically means that your acid or reflux, is controlled well during the day, but in the middle of the night or late at night, you might be waking up because you get heartburn or one of these other symptoms that could be extraesophageal. So there's a concept called acid rebound that can occur in the middle of the night. And this may be due to people eating too late at night, such that there's more food in the stomach, and when they lay down, they don't have the benefit of gravity to help reduce the chances of reflux occurring. It also may be due to the fact that while proton pump inhibitors taken twice a day offer very good 24-hour coverage, some patients may actually need a little bit of help in the middle of the night to really get better 24-hour coverage. And in these cases, we will use what is called an H2 receptor antagonist, as Dr. Roth mentioned. For example, Pepcid and Zantac are the most commonly available ones in the drugstore. And you take this medication just before bedtime, and this will help, hopefully, with achieving 24-hour control of your acid. There are a variety of medications that can lead to worse reflux. Two breakdowns can be either affecting the function of the lower esophageal sphincter, or the medication can damage the lining of the esophagus. So in terms of the first category, certain blood pressure medications, those that can relax the sphincter muscle, include nifedipine and diltiazem. These are the generic names. There's a variety of trade names, which I won't go through. Progesterone, which is a female hormone but can be found in birth control, and if you're taking hormone replacement therapy, that can also weaken the lower esophageal sphincter. And a variety of anxiety medications, Valium and Ativan are commonly known ones, can also affect the sphincter function. In terms of medications that can irritate or damage the lining of the esophagus, potassium pills, iron supplements, aspirin or non-steroidal anti-inflammatory drugs, two common names, ibuprofen and naproxen, can irritate or damage the lining of the esophagus. And then bisphosphonates, which are a wide category of medications used to help improve bone density or prevent the progression or reverse the effects of osteoporosis, such as Fosamax and Boniva, can also cause the damage. And if anyone takes one of these medications, you're told that you need to take the medication on an empty stomach and be upright for at least an hour to help minimize the chances of this occurring. Now, with regard to lifestyle measures, Dr. Roth again mentioned eating too late at night can worsen the reflux. And so we will recommend that patients try to give at least 2 to 3 hours between the time that they last eat and when they lie down to go to bed at night. This will allow for a better chance for sufficient emptying of the stomach to reduce the chances of reflux. He also mentioned weight loss, and I want to reiterate that point. Weight loss can go a long way to helping with reflux symptoms, although for most people, weight loss in itself will probably be insufficient to control reflux. And then again, the avoiding or minimizing certain dietary triggers. There are people who come and see me and they say, I've cut out tomatoes and orange juice and all the foods that are high in acidity and fatty foods and coffee and tea and so forth. And I say, well, that's fine, but did you notice if that food or liquid caused the problem for you to begin with, or did it get worse? No. Well, this goes towards quality of life issues. If there is a good medication, such as the proton pump inhibitors, that can help control the acid and allow you to eat the foods and liquids that you love to eat, why not do that, especially since it is so safe, and that way you can maintain your good quality of life, hopefully. Now, coexisting disorders. This picture may look generally familiar. This is a hiatal hernia, again, part of the stomach pushing through the diaphragm, and now you lose the synergistic effect of the diaphragm and the lower esophageal sphincter, which would be around here. This can allow for more reflux or acid reflux than can be controlled by acid-blocking medications. If someone has a completely incompetent or completely weakened lower esophageal sphincter, it's basically just like an open pathway for reflux to occur. And then other potential disorders, Dr. Roth had mentioned if you take a prokinetic agent, a medication that helps stomach emptying, that this was designed for people who have a condition called gastroparesis, where the stomach just doesn't move very well, doesn't empty. If there's an esophageal movement or motility problem, this can prevent effective clearance of acid from the esophagus. And then some people may have an increased sensitivity in the esophagus where the nerves are just so revved up that any exposure to acid or other types of substances, even if it's completely inert, will cause the symptoms of heartburn to occur. Now there's a group of people who they take PPIs twice a day and there's no effect whatsoever. These are called non-responders. So really most patients, if they don't respond to one PPI, they're not going to respond to another. To echo the sentiment Dr. Roth had made, really if someone says that they tried Prilosec and it didn't work, but then they went to Prevacid and they felt much better, I really can't explain that. Maybe there's something about the molecular structure of the drug that one works better than the other. Maybe it's placebo effect, it's hard to say. But if there is no improvement with a PPI or 2 PPIs or 3 PPIs, depending on when the patient comes to see me, I really want to look for another explanation for their symptoms. And such conditions include regurgitation, where stomach contents, not necessarily just acid, will move up through the chest and into the throat. This is different from vomiting, where it's more of a forceful occurrence. There's a condition called non-acid reflux, which I'll talk about. Hypersensitive esophagus, which I alluded to before. This can be grouped with another disorder called functional heartburn. And then 2 other disorders that I'll mention are eosinophilic esophagitis and achalasia. And I'll talk about each one of these in a little bit more detail. So I already described regurgitation. People who are taking PPIs, they may still have food or liquid come up into their throat and it tastes bland as opposed to sour because the acid component is gone. But PPIs do not prevent reflux in general from occurring, just the acid component. So if you have a completely weakened lower esophageal sphincter, food can still reflux up, and medications are not going to take care of that very well. So this can't be controlled by PPIs. and I mentioned a potential couple of reasons why this occurs. These patients may benefit from surgery, which Dr. Lee will talk about later on. And the surgery is called fundoplication, just as a heads up. Non-acid reflux essentially is what I just described as. This is reflux of fluid that is diminished in acid because either the patient's taking PPIs and the acid has been suppressed, or they have some type of underlying disorder that does not allow for adequate stomach acid to be generated. This can be diagnosed by a test called an impedance pH test. And this is a combination of tests rolled into one where you measure the pH or the acid level in the fluid, but you're also measuring for fluid coming up into the chest. And by combining the two, you can determine if the fluid is acid reflux or non-acid reflux. It's a little bit controversial as to whether or not this truly leads to esophageal damage. It can lead to some of the extraesophageal symptoms that I did mention. And in terms of how to treat this, surgery may be offered, but patients may not see the same degree or have the same expectation of improvement compared to those people who take PPIs and get good relief from their symptoms. Functional heartburn is defined as a patient who has heartburn symptoms. They have a normal appearing esophagus when someone puts a camera down to look at it. They have a pH test that is normal, and they take a PPI and it doesn't work. This is probably related to nerves that go to the esophagus and then go back from the esophagus and send signals to the brain. And these signals are amplified, so the esophagus, in a sense, is primed for any change in the environment, and it's going to send an amplified signal to the brain so the brain perceives that there's something else going on. Eosinophilic esophagitis is an allergic disorder that affects solely the esophagus. And this is becoming more and more well known as people are looking for it more. It was first described in kids, but we're seeing it in a lot of adults. There have been a variety of foods that have been implicated as a cause for their symptoms. However, it can be a little bit difficult to make that diagnosis because seeing an allergist and getting the skin testing tends to be very inaccurate when it comes to making the diagnosis of a particular food causing the symptoms. This is a benign condition, and just like reflux, it's a chronic condition. Most commonly, people will say that they have trouble swallowing the food, meaning that as they have something of a solid nature, it feels like it gets temporarily stuck in the chest or goes down very slowly. Sometimes they can get food stuck and they have to go to the hospital to get it removed. But not uncommon, people will experience heartburn as their symptom. This needs to have an endoscopy in order to be diagnosed and biopsies taken to show that there's an increase in a certain type of inflammatory cell called the eosinophil, which is where it got its name from. Patients who have eosinophilic esophagitis may actually be well controlled with a proton pump inhibitor, but a lot of people will end up requiring a topical anti-inflammatory steroid, similar to what is used for asthma to help control their symptoms. And if a food source can be identified for the cause of the symptoms, eliminating that food can also lead to resolution of the problem. Achalasia is a rare disorder that basically means that the sphincter between the stomach and the esophagus fails to relax. And at the same time, the esophagus doesn't function like it should. Normally, the esophagus moves through peristaltic contractions or sequential contractions from top to bottom to push the food down. In this case, the esophagus will contract at all levels at the same time, or it may not contract at all. And so what happens is food and liquid will just sit at the bottom of the esophagus because the sphincter doesn't relax well, and the food will begin to ferment with what little enzymes are available to help break down the food. And this can lead to the perception of heartburn, but patients will say that they've taken PPIs for the longest time and it hasn't made a single impact in their symptoms. Typically, patients will also describe trouble swallowing solids and liquids because the food just sits there. They feel the sensation of the food and liquid getting stuck in their chest. This requires therapy other than medications, either an endoscopic treatment or surgery in some cases. Before I get to the summary, so one other aspect that I didn't put on the slide here that will be discussed in a little detail later is esophageal cancer. The bottom line is people who have persistent heartburn symptoms or reflux symptoms who don't get better with a PPI should have an endoscopy to see if there is cancer or a precancerous condition going on. This is something that is uncommon relative to reflux. If you think of these disorders as buildings, esophageal cancer is like a 3-story condo, and GERD or reflux is like a skyscraper. So it's extremely uncommon relative to GERD, but it is something that should be excluded if patients don't get better with therapy. So finally, to summarize my talk, reflux, it can present in other ways other than just the typical heartburn. And if you have a partial response to proton pump inhibitor, you want to make sure, are you taking it the right way? Are you taking the proper dose? If there are certain lifestyle factors that you can modify without significantly affecting your quality of life, that would be helpful. And then your doctor should look for coexisting disorders that can be preventing adequate response to the PPI. And then finally, for the non-responders, really we have to look for another diagnosis for the symptoms. All right, thank you very much.